American Heart Association has just published updated cardiopulmonary resuscitation guidelines, and the update is the first since 2010, and it includes several changes, including quality enhancements in CPR. So to talk about this, I'm with Dr. Monica Kleinman, who is an MD and Clinical Director, Medical Surgical Intensive Care Unit, and Senior Associate in Critical Care Medicine at Boston Children's Hospital. What's new?
Well, there is some things that are new, some things that were continued from the 2010 guidelines, and some things that were updated. So what is different this time around is that we did not redo the entire set of guidelines with a new process. We looked at what was new in the literature. We updated the ones that needed to be updated. We added some new things, and then some things were carried along because there was no new evidence for them. Specifically, what's new in basic life support is some clarification of the definitions of high-quality CPR. And high-quality CPR remains the single most important thing for determining outcome from cardiac arrest. More important than our advanced life support, more important than the fancy gadgets that we have in the intensive care units. It's a good CPR. So one of the things that was specified that was clearly updated was an upper limit for the rate of chest compressions. And that is that the range, which used to be greater than 100, or at least 100 per minute, is now boundaried on the upper end at 120 per minute because of evidence that once you get above about 140 per minute, you start compromising the depth of compressions, and that trade-off is not in favor of the victim.
Right. In terms of chest compression only, remains?
For the lay rescuer, chest compression only remains the first go-to recommendation for dispatch-assisted CPR, and just for the average person on the street who you're trying to message that says anyone can do CPR. It's chest compression only. For healthcare providers, we continue to teach chest compressions plus ventilations, and for children, we emphasize that ventilations are extremely important to do with chest compressions.
And you've changed kind of a little bit the placement, the hand placement for compressions?
It seems like we have, but it's just different wording. There really isn't a different location for the compressions. In the center of the chest is the best definition for the lay rescuer. The lower half of the sternum is what is anatomically described for the healthcare provider.
So what else has changed or is now updated?
The chest compression depth has been slightly modified to again indicate an upper limit of depth. This is based on a small series from Scandinavia showing that excessive chest compressions, and when I say excessive, I'm talking about chest compressions that rather than being 5 centimeters or more like 8 centimeters, were associated with injuries.
Yeah.
Now, the last thing we want is to message the public that you can hurt someone with CPR.
True.
Because you really can't hurt someone in cardiac arrest. The only way to hurt them is to not do anything.
Right.
So we don't want the message to be confused. We still want push hard, push fast, so that patients benefit from high quality chest compressions.
Now, there are a couple of things that obviously aren't going to be in the guidelines because they're very recent. One I want to talk to you about is from the ESC meeting where we were at in London. In more than 17,000 patients, they reported that the probability of survival declines with each minute of CPR, but EMS personnel or clinicians should continue CPR for at least 35 minutes in patients who suffer cardiac arrest outside the hospital. What's the time frame that you are talking about in the guidelines?
That is a reasonable time frame, and no one knows exactly what it should be. This has to take into account individual circumstances, the age of the patient, the circumstances that the patient is found in, whether there's any mitigating factor. There are patients who have MIs, adult patients who have MIs, who are taken to the cath lab after prolonged periods of chest compressions, who actually have good neurologic recovery after they get revascularized. So it's very difficult to set an upper limit beyond which every patient should have CPR stopped.
I mean, what they found was that 35 minutes was probably outside, minimal gains afterwards, and CPR leads to absolutely no benefit from 53 minutes onwards, is what they found.
And that is certainly the best information we have right now based on a really large study. I can tell you that in children it's different, that big registry studies have shown successful outcomes even after more than an hour of chest compressions. So I don't know that we're willing to be very absolute about it right now. It is reasonable to think about it at that 30, 35 minute mark.
I'm glad you made that distinction though about children. Here at this meeting, and published in the New England Journal of Medicine, continuous or interrupted chest compression during CPR. I know you saw that session.
Yes.
What do you think about it?
Well, it was a lot of data presented and a very, very impressive study. To coordinate and carry out a study like that with something like 99% recovery of data is an incredible feat through the ROC Consortium. What they found was that they compared the standard chest compression ratio to ventilations of 30:2 with patients who got several sets of 200 compressions in a row with either some bag mask ventilations during those continuous compressions or some passive oxygen during those 200 compressions. And this approach, this 200 compression set approach with delayed ventilation has been used in certain systems, has been tested in certain systems where as part of a bundle of care that people use to try to improve outcomes with specialized training for a unique group of providers has been shown to improve their outcomes. What this study looked at, though, was doing it across a large range of systems, very heterogeneous population of patients, and found that there was no improvement, no benefit to doing the continuous chest compressions for that period of time with delayed ventilation as compared to doing the 30:2 that we standardly do.
Anything else that you saw at this meeting that got your attention?
Well, there's continued refinement of the recommendations for targeted temperature management after cardiac arrest. So for those victims who survive the cardiac arrest event but remain comatose afterwards, we continue to better understand the role of hypothermia, the duration, the exact temperature that you should cool to, and how you should then wait to prognosticate because of the use of hypothermia.
Now, the very last thing, this is kind of a pivot point. You know, the last update was 2010, you're now 2015. From here on out, you're going to do things a little differently in terms of CPR guideline updates. Can you describe that? Because you mentioned it in the paper.
Sure. I said yesterday when I gave a presentation that I hope not to be here in 2020 doing an official guidelines update because we want to move from this periodic cycle where there's a big bang every 5 years to a more continuous process. Obviously, the study presented yesterday is very important to include in our consideration. It may not by itself be enough to make an entirely new guideline, but it would be a shame for it not to be taken into account for 5 years. Yeah. So we want to look at a more continuous process of updating the guidelines, which requires evidence review, careful definitions of when something meets the threshold to change a guideline, right, and then a very nimble way to disseminate the guidelines, change training materials, and essentially try to change practice more quickly than we can right now.
I mean, that's one of the things the ACC has been doing in some of their guidelines. They will just produce an update, sometimes very targeted, relating to maybe one or two different papers. Yes. that get released, or maybe a series that gives us in a new direction. So I think that's obviously the way to go for the 21st century. And maybe we won't see you in 2020, but if you could come by and at least update us occasionally every once in a while we're doing at these meetings, would that be okay?
Of course. Happy to.
We have a variety of coverage from the AHA meeting, so please check that out in print and online. And for Cardiosource World News, I'm Executive Editor Rick McGuire.